Good evening. Welcome to the January 9th, 2013 meeting of the Washington Township Healthcare District Board of Directors. If you'll join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Catherine, can you call the roll?
Yes. Director Nicholson.
Present.
Director Wallace.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Director Egan.
Present.
Thank you. Nancy, can you introduce our educational session?
Yes, I'd be very happy to. Tonight, we're going to have a presentation that is Legislative Affairs Update. Elizabeth Goodman-Bacon is going to be making that presentation. She received her undergraduate degree from Harvard University in psychology with a secondary degree in health policy. Currently, she is the Legislative Affairs Coordinator at Washington Hospital Healthcare System. In this role, she is responsible for tracking key state and federal legislation and implementing assigned strategic projects related to state and federal reform implementation. She's been at Washington Hospital since June of 2011. Before coming to Washington, she worked for the Advisory Board Company, a healthcare consulting firm in Washington, D.C. Elizabeth is a resident of San Francisco and more commonly goes by the nickname Busy.
Hello, everyone. Many of you I know. Those of you who don't, I'm Busy. Right. So I'm just going to do a brief overview of what I do here at Washington, as well as an overview of what's happened in the last session, and then talk a little about what's going to happen in the year ahead. So it'll be very broad because we don't know exactly what's going to happen this session, even though it started this Monday, but there's a lot in the pipeline. So first, my primary responsibilities, as Nancy touched on, tracking legislation at the state and federal level, and also advocating or sponsoring legislation of interest or as necessary. I also serve as the liaison for state representatives as well as our California delegation in Congress. So Washington's elected representation has changed a lot since the 2012 election, but also due to redistricting in 2011. The 14-member commission that was authorized to perform the redistricting, the California Citizens Redistricting Commission, redrew district lines in 2011, and it was supposed to help ensure that there was fair representation throughout the state. So the good thing is that Washington gained sometimes dual representation in some of the legislative bodies after the redistricting. That's a good thing for us in that we have two people that will advocate for us when necessary or that we can reach out to when we need to. So first, our congressional delegation is split between the 17th district and the 15th district. In the 17th district, we have Mike Honda, and that represents Fremont, Newark, Milpitas, Santa Clara, and Cupertino. The 15th district, which is a newer district, is represented by Eric Swalwell, who in that district includes San Ramon, Dublin, Pleasanton, Livermore, Castro Valley, Union City, Hayward, Fremont, and parts of unincorporated Sunol. At the state Senate level, not as much change. We're still represented primarily by Senator Ellen Corbett in the 10th district. We did lose parts of unincorporated Sunol and Pleasanton, and those are now represented by Senator Marc D. Saunier in the 7th district. And in terms of assembly districts, we're now split between the 20th and the 25th districts represented by Bill Quirk and by Bob Wykowski, respectively. The 20th district, Quirk's district, includes Ashland, Castro Valley, Cherryland, Fairview, Fremont, Hayward, San Lorenzo, Sunol, and Union City. The 25th district, which is Bob Wykowski's, that includes South Fremont, Milpitas, Santa Clara, and North San Jose. And our physical address is really on the border there. But our district will be represented by both of them. So I'll just go over very broadly the legislative process and how a bill moves through legislature. For some of you, this may be commonplace, but I find it helpful just to go over how a bill moves. It's often helpful in understanding how policy decisions are made or sometimes undermined. So our state legislature is made up of two houses, in the Senate and the Assembly. Our Senate has 40 members and our Assembly has 80 members. Each legislative session is 2 years, so we just finished a 2-year session and began the new one for the 2013 and 2014 in January. All the bills that were passed last session became became law on January 1st. So now we're a fresh start with new bills being introduced by the day, and legislature is already in session now holding hearings. And then I'll talk a little bit more about how the bill moves through, as you see some information there in terms of what the governor's role is in each bill that comes through, but I'll go through that a little bit more detailed in this next slide. So this is a good visual for how the bill moves. It looks a little bit like a kindergarten drawing, but it really is a good representation of how a bill moves through the entire process, at least in the most smooth form. It's often not as simple as this. Often it gets sent back and forth, as you'll see the other arrows there. So all legislation begins as an idea or concept based on some kind of issue that's recognized by an elected official. So the legislator or the author will bring that concept to the Office of Legislative Counsel, and that counsel will turn it around and write it into bill form. The draft of the bill is then returned to the author or the legislator to introduce within their house. So if a senator introduces a bill, it'll be read first in the Senate. If an assembly member introduces a bill, it'll be read in the assembly first. After it's introduced, the bill will be sent to the Rules Committee. In the Rules Committee, that's where they will assign a policy committee for every bill. So if it's a health-related bill, it'll go to a health committee. If it's a budget-related bill, it'll go to fiscal appropriations committees, et cetera, et cetera. After it's in the policy committee will write up an analysis that sort of explains what the bill does. And it also outlines usually the supporters or any opposition that exists on file. Those are really helpful documents to sort of look at and really understand what exactly would be changing in the law and what the impact would be. So after the policy committee writes up those analyses, they'll send it to the other floor in the other house, and they'll vote on that bill. But often this is where the amendments come into play, and if there are changes that need to be made, sometimes it needs to go back to the policy committee or back to the other floor to be voted on again. It's very, very rare for a bill to go smooth sailing all the way through. If it's voted on in the second house, then it'll go straight to the governor. Again, like I said, with amendments, it'll sort of go back and forth for a little bit and then eventually make its way to the governor. The governor does have three choices once he receives any bill that's made it through. He can either veto the bill, he can sign it, or he can sign it passively, which means that he just doesn't physically sign the bill, but has garnered it as one of the new bills that will be passed in January. Sometimes the governor will leave notes with each bill, depending if he's going to sign or veto it. Those notes are really useful to look at from a policy perspective and also for legislators. Often those will give you an insight into what the administration's thoughts on or their policy priorities are for the given session. And it's also good for legislators to go back and look because it gives them some insight into whether they can reintroduce the topic and remove some of the items in there. So sometimes you also find some very entertaining pieces in there depending on the governor. All right, so given that we just ended a 2-year session, I'll just give you a broad overview of what happened in the last year of the 2011-2012 session and how it relates to Washington Hospital and what we've been really focusing on. So first, and this is a timely topic given that tomorrow the governor is due to submit the budget legislation for the upcoming year. Once the governor must submit it by January 10th every year, and then the budget that he proposes will eventually take form in a series of bills or trailer bills that will be passed by mid-June. So last June, the 2012 and 2013 budget was passed. Did balance the $15.7 billion budget shortfall. That deficit was reduced to about $7.3 billion with the passage of Proposition 30 in November, the governor's tax initiative. So that was a significant improvement to the deficit, and it's led to the LAO, the Legislative Analyst Office, their most recent fiscal outlook for the upcoming year to be remarkably positive considering the last decade of LAO fiscal outlooks. For the first time, the LAO has used the word surplus in their report and suggests that we could potentially have a surplus by 2015 and growing throughout. You can't rely on this because a lot of it will depend on the budget this year and a number of other factors, obviously, but it is worthy to note that this is the first time the word surplus has been used in even a fiscal outlook in a long, long time. And for those of you that aren't aware, Prop 30 was a real focus of the governor last year to try and get that passed, and that's going to raise sales tax and income tax in California, but bring a lot of revenue into the general fund. The only thing the governor has been vocal about so far, we'll find out everything tomorrow, about this year's budget is mainly to overhaul school funding. There's not a lot of specifics there, but that has been sort of the one point that he's at least been vocal about that he really wants to address this year. And we'll talk a little bit later about some of the other healthcare related topics that will probably be addressed or should be addressed at least in this year's budget. So in last session, a majority of the healthcare-related bills had to do with healthcare reform implementation, which is probably pretty obvious given that it's 2012 and 2014 is a big landmark in healthcare reform implementation in the long term. The governor was able to pass some broader reforms, which came without controversy, but were certainly considered successes from the governor's administration, one of which was pension reform, workers' compensation reform, redevelopment funds, which a lot of people are not very happy about, and prison realignment. The most notable exchange-related bills, as I said, usually had to relate to reform implementation, but specifically the healthcare or the health benefit exchange. So California is moving ahead with the exchange, as many of you may be aware, as you've seen in the headlines. So a lot of the legislation last year and probably this year as well will be ironing out some of those regulations and how the exchange is run and how it's set up. Some of the more memorable and bills that you might have heard of in the news did not get passed this year. So one that might be relevant to Washington, there was a bill that was posed to ban tobacco use on any hospital campus. That got vetoed by Governor Brown. There were a couple others, including a basic health plan, which will come back up again later and I'll mention, and a few others in terms of emergency room overcrowding reporting. But again, most of the bills that were signed had to do with the exchange if they did in fact make it through. But I think a lot of the bills that we saw last year will probably be reintroduced in some form next year because there are some reoccurring themes, which I'll mention a little bit later. So here are a few of those exchange bills that I mentioned that did end up making it through. 1453 and 951 was a small group benchmark. This was really crucial for the exchange in that it established sort of a benchmark for the essential health benefits that would have to be included in any small group plan. So this, as of 2014, all small group and individual health insurance policies in California must cover the health benefits covered within this Kaiser small group plan. So this will apply to policies sold in and outside the exchange as well. So this was sort of the first benchmark bill that made it through. It was a win for Kaiser, and they looked at a number of different plans to sort of see what was the best benchmark to use, and this is one that made it through. And the only reason I have two bill numbers there is that they both sort of addressed that same that idea in different ways, and we needed both of them. They were sort of relying on each other. 792, notice of coverage options. This just helps ensure that people have no interruption in coverage when they file any kind of legal change, including divorce, unemployment, adoption. And this, basically the state will send them a letter that says, we saw that you filed for divorce or unemployment. Here's your coverage options if you're going to lose coverage. You can go into the exchange, or here are your other options, basically. That was a very popular bill actually going through. 1761, there are a few others that are like this. This just helps prevent deceptive marketing on behalf of plans or policies or websites or newspapers, just to make sure that no one's out there saying, hey, we're part of the California Exchange, or we're an exchange offered plan, just to make sure that none of that stuff gets through, because the whole point, or the state really wants to make it as easy as possible for a consumer to come in, find the exchange, find the plans that are available, and any kind of misrepresentation would certainly make that process deceptive. So last year, a lot of the bills did get held up due to sort of three major obstacles that we're all probably familiar with. Certainly the Supreme Court challenge last spring sort of kept a lot of things up in the air. The presidential election as well as the general election. All of those decisions sort of left a lot of things uncertain for legislators, providers, so that a lot of policy decisions were sort of slowed down. People put the brakes on a lot of things that they were hoping to accomplish or wanted to accomplish. And then lastly, voters' approval of new taxes that took such a lead in a lot of the political conversations going on that I think it distracted a lot from some of the other policy initiatives that could have happened or have happened in the past years. We have a lot that's going to happen in this year, though, I think. Certainly the Medicaid expansion is one of the most important policy pieces that's going to have to either be addressed this session, and legislature is actually in a special session right now just to discuss healthcare-related bills and what legislative options are out there. So one of them is this Medicaid expansion. So the federal reform law, the Affordable Care Act, does authorize or ask that states expand Medicaid to 138% of the federal poverty line, but not all states have to do that within their own legislature. So California is deciding right now whether to do that within a bill. it's sort of interesting in California because given the low-income health programs that are established within each of the counties due to the section or the waiver that was implemented in 2010, a lot of counties we already cover people within that grouping, but it will be a big decision of whether we go forward with it on a state level and say that we're going to meet the federal act's requirement to meet that 138%. Governor Brown, their administration has sort of been wishy-washy on this. They recognize that there's a huge incentive there and that the federal government will cover those costs for the first 3 years at 100% and after that 90% until 2020. So there's a lot of money coming in or potentially coming into the state. They estimate that federal support could be between $2 and $3 billion for Medi-Cal to California by 2014 and then growing to about $3 to $4 billion by 2019. Although they recognize that there's a lot of risk there because it certainly could cost the state a lot more in the long run. Even if we got those extra dollars now, it's certainly not many people believe that that'll be enough to cover this new population. So there's going to be a debate there, but a lot of the legislators are really gunning to move this through, and I think both the Secretary of Health and Human Services, Secretary Dooley, as well as Governor Brown recognize the risk. Second thing is individual market reform. This has really been pushed by Senator Hernandez, the chair of the Senate Health Committee. He introduced a couple of bills last year that would just ensure that Californians are never denied coverage due to pre-existing medical conditions and also medical underwriting. So he's been really vocal about wanting to reintroduce some of those ideas. That's not really that unique. I think given the circumstance with the exchange, there's a lot of opportunity there to pass individual market reform bills, but Hernandez has sort of been preaching that for a while. Basic health plan option I mentioned a little bit earlier. So this idea is that the state would introduce a new basic health plan to cover those that wouldn't be within the exchange or aren't within Medi-Cal, sort of that in between. So theoretically, it would be between the 133% and the 200% of federal poverty line. There's a lot of conflicting viewpoints of whether this would be a good thing. The ACA, the Affordable Care Act, does recommend and authorizes states to be able to introduce this kind of health plan, but some people believe that it's going to be great to provide coverage to this population and that it's really necessary, while others are sort of concerned that introducing a basic health plan will sort of siphon some of those healthier individuals out of the exchange and to enroll in this plan, and that the exchange will be left with the sicker individuals. So there'll be a lot of controversy over that one, and there has been in the past couple of years. They always try and introduce a bill there. I'm not sure whether it'll go through either way. And like last year, a lot of bills around exchange plans and consumer enrollment and eligibility and how those processes really work within the system. Okay, so I'll move a little bit on to federal legislature and just give you sort of a quick overview of Congress and what's going on in DC. There's always a lot, so I'll make this very broad. Congress is made up of two houses, the Senate and the House of Representatives. There are 100 members in the Senate, 435 members in the House, and 6 non-voting delegates. Each regular session is 2 years long, and the Congress is currently in the 113th session right now. Our Speaker of the House is John Boehner, who many were skeptical would be reelected last week, but was, and the Senate Majority Leader is Harry Reid. Most legislation is introduced within the House, which includes revenue bills, but that's by rule. Appropriation bills are introduced by the House, usually by tradition. And similar to a state, the bills become law immediately when they're signed unless an effective date is included within the bill. So the most recent happenings within DC, is I'm sure many of you are aware of, was the fiscal cliff legislation that was passed last week. Congress passed H.R. 8, which averted the fiscal cliff, or at least kept us from falling off of it, but sort of kicked some of the other things down the road, which I'll talk about a little bit in the next slide. The main components of this bill, and I emphasize that this is only the main components, there's a lot in there that many people are still sort of sifting through, but these are sort of the primary tools within the bill to keep us afloat, I suppose. Higher taxes on individuals earning $400,000 and above, families earning $415,000 above, higher tax rates on capital gains and dividends, estate tax raised to 40%. The SGR, Sustainable Growth Rate Fix, was just extended for another year, and this is important for us, but this is paid for by provider cross subsidies, which I'll also talk about a little bit. The sequestration was delayed for 2 months, so in 2 months expect just as big of a battle as you've seen in the last couple of weeks. There's going to be a lot talked about. I don't know how much is going to be accomplished, but that whole discussion was just sort of put down the road. Alternative minimum tax rate was indexed to inflation. This was a big one that the Democrats were pushing for. Emergency unemployment benefits were extended for a year. This was another good one. And there's a few other things within there, including that have to do with college debt and college loans that went through as well. But these are sort of the major components of that bill. So like I said, they did address some of the major topics that would have sort of put us off that fiscal cliff, but there's a lot that was sort of kicked down the road. First, an agreement to raise the debt ceiling, and this will probably come up in a couple of months as well. They didn't even mention that in the bill. Extension of Social Security payroll tax cut, that temporary 2 percentage point cut to the payroll tax did expire on December 31st, and that will certainly cost many Americans a lot more money. And then a grand bargain, as they say, in terms of entitlement reforms. And that'll come up again in a couple months in terms of Medicare is going to be talked about a lot, Social Security. So there's a lot sort of at stake here, and no one really knows whether Congress, what they'll do about it. And I'm sure it'll be just as dramatic as it has been recently, knowing this Congress. So here's some of those offsets that I mentioned that are going to help pay for things like the SGR fix. Most importantly is this documentation and coding adjustment. This is basically the government's way to sort of look back at payments and that they think that the hospitals were sliding up based on when we switched over to MSDRGs and collect money from that. But they put $10.5 billion on this, so that's huge. And some people aren't sure whether that's accurate and whether they'll be able to get that much money back, nor do we know how they're going to collect those and what the formula will be. But that's certainly something to be aware of, because that was one of the largest offsets that they put a number on, and will certainly be an impact to us. And we're looking at that right now to sort of get a better understanding of how it will impact Washington. Rebasing the disproportionate share hospital payments, they put that at $4.2 billion. And then lastly, rebasing end-stage renal disease payments. This just sort of incorporates recommendations from the General Accountability Office by repricing the bundled payments that take account changes in behavior and efficacy of drugs for dialysis. But they put that also at $4.9 billion. So those are just some of those. Those are sort of the biggest ones on the list. There are a number of other offsets, but those are the ones that I really wanted to mention today. So that's a very broad overview. I hope that was helpful. Here's my email address and phone number. If you do have questions, I'm here, and I'm constantly learning about these things and trying to understand what's going to matter for Washington. So hopefully this was helpful for everyone.
Thank you very much, Busy. Any questions?
I had a question. What is the federal poverty line? What
133. Oh, so right now Medicaid is set at 133% of federal poverty line.
And what is, I understand that.
Oh, okay.
What I need to know is the actual dollar amount of the federal poverty line.
I don't have the dollar amount on me, but I can certainly get back to you.
Be curious to know what that is.
Yeah, it's different. Obviously, well, I'll look in the numbers and get back to you.
I think one of the things that's important to recognize is that along with looking to get an additional $10.5 billion out of hospitals, they have extended the number of years they can now go back and look at from 3 to 5. And the coding system that they're objecting to, that they feel that they now want to go back and re-examine, is a coding system they themselves invented and introduced in 2008. And their intention at that time was to use severity indices to disallow payments. And it backfired on them, and the hospitals and providers were able to use those self-same diagnostic-related grouping details to justify additional payment because of the severity of illness of a patient. And so they, I think, profoundly regret having introduced ICD-9 and are now trying to undo some of the unintended consequences, which was to pay hospitals fairly for what they were doing.
Well, they are the ones who make the rule.
Yeah.
And this is another example of the golden rule. He who has the gold makes the rules.
That's right.
And it looks like they're going to be changing the rules upon us. And I think the bottom line, Busy, that I see from your presentation is that we have a lot of uncertainty in our relationship with these governmental entities and how they will affect the practice and economics of healthcare.
Absolutely.
Thank you very much.
Thank you.
Okay, let's go on to our consideration of minutes from December 12th and the 20th, 2012. Do I have a motion?
So moved.
And
Second.
we have a second from Dr. Stewart. All in favor?
Aye.
Aye. Any opposed? Motion passes. We have communications. Catherine, do we have any cards? No cards, but we have another presentation, I understand.
Mr. Henry, I'm not sure how we want to do this, but,
In front of the cameras, Pat.
oh, in front of the cameras, in front of the cameras. I'll have to hold this for you since you are, infirmed. I would, on behalf of Newark Days, I was notified late that there was a trophy waiting for us. And the screen, and I said that I have to read this. Newark Days Parade, 2012 Classic Vehicle, first place.
Wonderful.
You all have to understand that, pretend like you're holding it.
Okay.
Since it's his car that is the classic, he deserves the trophy. Congratulations.
Thank you. Well, since I did this on behalf of the hospital, I'm gonna turn it over to Nancy and we'll put it in.
Oh, no, this goes to your house.
None of us want to dust it.
This
to your
this
house.
is the only thing this car's ever won.
I was going to say,
You have to understand, the folks have to understand, you built that car how many times?
Oh,
Built and
it's an
rebuilt?
ongoing process.
It's an ongoing process, so, and he very generously gives of his time to represent the hospital, so it's your trophy.
Thank you.
You're welcome.
I think what's not being said is that Chris's away from work hobby is a Cobra. And he belongs to a club. And he has taken the car apart many times. I think it was last Christmas, his family Christmas present to him was to put one of those lifts in the garage so you could raise the car up and work on it. So, that Cobra is his baby.
great. Chris, I'm sure this is the first time you've won first place going so slow in the parade.
It's the only thing, it's one that I'll admit to.
All right, okay. You can tell us about the others later. Let's move on to written communications. Dr. Romano.
Okay, I'm pleased to present the credentials action items from the medical staff for December of 2012. First are the appointments. We are recommending approval of the appointment and the privileges as delineated for Doctors Bogdan F. Timi in Hematology Oncology, Brian Adams in Dentistry, Thomas Harai, General Surgery, and Debbie Paichun Sith in Podiatry. We are recommending that you grant 2-year reappointments to Doctors Peter Barnett in Emergency Medicine, Stephanie Chang in Pediatrics, Joyce Cho, Internal Medicine, Edward Cohen in OBGYN, Luis Falan, Internal Medicine, Vineet Kapoor, Intensivist, Lisa Lamb, Family Medicine, and for Randy Mistretti, Physician Assistant. We are recommending advancement to the from provisional courtesy to courtesy for Dr. Gregory Perrone, a teleradiologist. We are recommending that you discontinue the proctorship for Randy Mistretti, Physician Assistant, and advance him from the Allied Health provisional category to Allied Health, and to complete the proctorship and advance Dr. Jeffrey Thomas from provisional to active in neurosurgery. And finally, in a shortened month, we are recommending that you extend the proctorship and therefore the provisional category for Sachin Parikh in otolaryngology and Monette Thiel, a cardiac perfusionist. That's the end of my report.
That was a short month. Okay. Great. Thank you very much, Dr. Romano. Do we have a motion for approval?
I move.
We have and a second?
Second.
Second from Dr. Stewart.
Oh, I'll correct that. Second.
All right, thank you. All in favor?
Aye.
Aye.
Any opposed? Motion passes. I think it's Sharon, Service League report.
Good evening. Most of the Service League members were on vacation or taking a relaxing break and enjoying the holidays. However, not everyone. The Service League gift shop was recently closed so that their point-of-sale system could be upgraded due to the current system software no longer being supported. This system tracks sales through the cash register, tracks inventory, and produces a variety of merchandise reports. All adult and student volunteers are now trained on the new cash register system. The gift shop managers, Joyce Wallace, Fran Stone, and Linda Orr, have put in some really long hours to help get it up and running, along with the help of our IS department. Thank you, ladies, for a job very well done. As our volunteers are taking down the holiday decorations, the membership committee is busy planning the update of our Service League webpage to better describe the various services that we bring to the hospital. I've been busy with our February 4th annual meeting, which is less than a month away. Along with a business meeting and lunch, we will have installation of our new officers and presentation of our donation check to the hospital. We will provide an annual report of this year's Service League events, along with acknowledging our volunteers' years of service. I hope you all will be able to attend. Thank you.
Thank you so much, Sharon. So good to see all of the good work that the volunteers do.
Thank you.
We have medical staff report. Dr. Romano again.
Again, so on the first page, you'll see our medical staff statistics. In summary, we have a grand total of 542 members. 358 of those are active, 27 are provisionally active, for a total of 385 active and provisional active members. Second page are the applicants which you approved this evening. The third page there is the status of all applications. We have 11 pre-applications out there. We have 15 applications in process, and 5 of which are inactive at the present time, and that is my report.
Thank you very much, Dr. Romano. Medical staff continues to grow.
It does, along with the problems.
I'm glad you're working hard on them.
Yeah, exactly.
Good. Nancy, hospital calendar.
Hospital calendar, Joe, please.
Past health promotions and outreach events. On December 6th, the Newark Chamber of Commerce held their annual holiday luncheon. The event honored Nancy Allen for her continued service to the Newark Chamber of Commerce. Washington Hospital was a sponsor of this event. Patricia Danielson and Dr. Bernard Stewart represented the Washington Township Healthcare District at this event. The Chamber estimates that 125 people attended. On December 19th, Lucy Hernandez, Operations Coordinator, presented to the Newark Optimist Club. Information was provided on the Community Health Resource Library and the hand-washing education program being presented at local elementary schools. 24 people attended. On January 3rd, as part of the Diabetes Matters series, Diana Jaycox, RN, presented Diabetes Resources, Where to Go for Help. 9 people attended. Upcoming health promotions and community outreach events. On January 15th, from 6 p.m. to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, will present Stroke Prevention and Other Disease Processes and Healthy Lifestyle. Be smart and avoid stroke. On January 16th, from 12 noon to 1 p.m., as part of the Washington Women's Center Lunch and Learn program, Anna Mazzei, registered dietitian, will present Healing Soup. Whether comforting a cold, nurturing a friend, or enjoying with your family, soup can be healing. 3 soups will be prepared during this live cooking demonstration. On January 26th, from 10 a.m. to 1 p.m., Washington Hospital will host the annual Abdominal Aortic Aneurysm Screening. Aneurysms develop over time and may have no symptoms, but if one bursts, it can cause immediate and life-threatening symptoms. Dr. Ash Jane, cardiologist, and Dr. John Thomas Mahegan, vascular surgeon, will be on hand to interpret results from this Doppler screening. This event is sponsored by Fremont Bank. On January 29th, from 1 p.m. to 2:30 p.m., Dr. Gabriel Herskew, vascular surgeon, will present treatment options for varicose veins and chronic venous disease. This event will be co-sponsored by Washington Township Medical Foundation. On January 30th, Kimberly Alvari, registered dietitian, will present on gluten sensitivity to employees of Boehringer Ingelheim. Boehringer Ingelheim is a worldwide pharmaceutical company with a facility located in Fremont. On February 5th, as part of the Washington Women's Center Lunch and Learn, Dr. Vandana Sharma, oncologist, and Nikki Chun, certified genetic counselor, will present Cancer in the Family, Am I at Risk? On February 7th, as part of the Diabetes Matters program, Dr. Ashjane, cardiologist, will present Protecting Your Heart. On February 12th, as part of the Stroke Education Series, Dr. Ashjane, cardiologist, and Doug Van Houten, RN, will present Acute Management of Stroke and Chronic Care and Stroke Rehabilitation. The Washington Hospital Healthcare Foundation Report. The Leos Club of James Logan High School and Moreau Catholic High School presented the Washington Hospital Healthcare Foundation with 600 holiday cards for patients at Washington Hospital. Cindy Nguyen, president of the James Logan Leos, worked with 200 members to create cards to bring good cheer to patients. Helen Kennedy of the Union City Lions Club facilitated the project. The Leo Clubs are high school affiliates of the Union City Lions Club. The Aeropostale clothing store, based in New Park Mall, donated 48 teddy bears to Washington Hospital. Each year, store managers have the opportunity to choose a local organization to donate towards, and Washington Hospital was chosen this year. The bears were presented to patients over the holidays. Washington Hospital Employee Association, WIA. On December 14th, WIA hosted the annual Children's Holiday Program featuring bubble entertainment, sing-alongs with Frosty and Rudolph, and photo opportunities with Santa. Admission tickets were $5 per person. Those in attendance were treated to chocolate chip cookies and hot cocoa. 20 $10 Toys R Us gift cards were raffled off to those who donated canned food for charity. All canned food was donated to Holiday of Wishes, a nonprofit organization benefiting families from several elementary schools in Fremont. In December, WIA hosted an employee appreciation event where coupons for various activities, services, and goods were available for purchase. Employees could purchase discount coupons for iFly, hotels, bay cruises, pizza, Subway, Annie's Pretzels, car washing services, rock climbing, bowling, Tommy T's comedy clubs, and many more. Over 1,000 coupons were purchased for a grand total savings of approximately $250,000. In December, WIA also supported local charities by coordinating holiday wish trees. Unwrapped new toys were donated to the Seneca Center, a nonprofit providing community and family-based services options to emotionally troubled children and their families. Gift cards were donated to Abode, an agency that offers housing programs linked to support services for low-income and homeless families and individuals. And SAVE, a local organization providing support services, advocacy, and education to domestic violence victims and their families. Washington on Wheels, WOW, Mobile Health Clinic. During the month of December, Washington on Wheels Mobile Health Clinic, also known as WOW, provided health care services at several community sites and schools located throughout the Tri-City area. In addition, WOW provided TB skin screenings to employees of Newark Unified School District. 38 TB skin screenings were administered. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was December's most viewed webpage with 11,245 views. Other active sections include InHealth, Channel 78. Washington Hospital's cable channel 78, InHealth, aired a number of new programs, including a public service announcement thanking the community for supporting Measure Z, 2 community seminars, diabetes control, back to basic keys for success, and dietary treatment for celiac disease, along with the Citizens Bond Oversight Committee meeting and the December board meeting. Other updates. On December 17, 2012, California Attorney General Kamala Harris held a public meeting at Hayward City Hall regarding the proposed management and sale of St. Rose Hospital to Electo Healthcare Services. Washington Hospital staff attended the meeting. Over 30 people spoke. It is estimated that the Attorney General will issue a decision in the middle of February 2013. For information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070.
I'd like to conclude the calendar presentation with announcing our Employee of the Month, Gurmeet Chauhan. She is someone who began their employment in 2002, and she was hired as a certified nursing assistant. She has recently moved into the unit clerk role. She works on 5 West in both the medical surgical unit and the cardiac surveillance unit. She moved to the United States from India about 15 years ago. She met her husband here in the United States, and they have a son who's 12 years old. To say she's a hard worker is probably an understatement. I'm sure that you're well aware of that, Dr. Nicholson. And she is somebody who's always willing to help. She never hesitates to go the extra mile. And I think everyone believes that she's very deserving of this recognition. We want to offer our congratulations to her.
Absolutely. I know Gurmeet well.
Yeah.
A great example of our employees.
She's
very hardworking.
Very special.
And so pleasant to deal with.
Yeah.
Really just sets the tone for 5 West.
That's it?
That's it? Okay.
Yes.
All right, we'll go on to quality report. Stephanie?
Happy New Year. The quality journey continues, and tonight I'm going to give a brief overview of our nursing administration observation process. The whole purpose of this study is to observe the key practices and errors in administering medicine. This came out of CalNOC, which is a collaborative alliance for nursing outcomes. This is the first nursing quality benchmarking registry in the U.S., and it was started in 1996. We joined CalNOC in the early 2000s. Medication administration study was piloted in 2005 with 5 hospitals. There are currently 33 hospitals participating. Washington Hospital has been part of the study since October 2010, and we presented at a CalNOC conference in Sacramento, June of this year. And one of the reasons we were asked to participate in that conference is to talk about our process. We have a very sound process where we engage the staff. The staff are the ones that are doing the observation. We have made it a learning and educational process for our staff. They are very much involved in terms of the action plan, in terms of the data collection and knowing what's done. While other hospitals were using consultants as the observer, we use our nurses as the observers. To give you a little background in terms of the medication administration and error process. According to ISMP, the majority of medication administration errors in hospital are unreported because of lack of awareness and error that have occurred. They felt that the most reliable method to determine medication administration accuracy in nursing was through direct observation. So the whole objective of the study is to ensure that medication is administered exactly as ordered by the physician as recorded on the patient medical records. The 5 rights: the right patient, the right drug, the right dose, the right time, and the right route. And it also looked at the safe medication administration practice, patient safety, as it relates to prescribing, transcribing, dispensing, administering, and monitoring. In order for the study to be valid, we have to collect 100 medication observations per unit. It is done in 1 day every quarter. The study has 2 steps. The whole process has 2 steps. The first step is a naive observation methodology. This is where an unbiased nurse observes the medication administration from preparation to administration. And then there is a reconciliation of what they observed versus what's in the medical record that has been ordered by the physician. And this helps determine the number, the type, and the frequency of the errors. In terms of elements that the study looks at, it looks at unauthorized drugs, which is the drug was not ordered by the physician, wrong dose, wrong form, wrong route, wrong technique, extra dose, omission, wrong time, drug not available. And each of these have a definition that's associated with them. They also look at the safe practice element, making sure that we compare the medication that's given to what's being prescribed, looking at distraction and interruption during the whole preparation of the medication process, looking at the labeling of medications, ensuring that 2 forms of patient IDs are checked before administration of medication, explaining the medication to the patient, and last but not least, charting the medication immediately after administration. Let's look at some of our results. When we first started the study, it has evolved over time. It was new to the staff. They weren't comfortable with people observing their practice, so there was a lot of growing pain as we began this participation. But we have grown over time. The arrow that says up means we're doing better, and you can see we are the benchmark in terms of CalNOC for overall observed doses with no errors. Looking at wrong time, and the definition of wrong time is either 60 minutes before or after the scheduled dose of that, the scheduled time of that medication. And this oftentimes is a challenge for us because there are many system issues involved. And the medication nurses and the medication team are working to decrease some of those challenges. And again, you can see over time we have come down quite nicely, and we are in line in terms of what the benchmark is with CalNOC. Drug unavailable. Again, this is looking to make sure that within that time frame, 60 minutes before, 60 minutes after, if the reason for the drug not being given is that the drug was unavailable. And there are many issues associated with that we have discovered that the staff have worked on, and we are beginning to see results with this. Let's look at some of the safe practices. Distraction and interruptions. This is key for us because this is something that we continue to struggle on, and this is going to be the focus for this coming year. And again, we are above the benchmark for CalNOC. And I'll talk a little bit about that later on in terms of what are the plans. Explaining the medication to the patient. The goal is 95.7%, is to get us there. We were 94.1% for the quarter. Comparing medication to what's ordered versus what was observed given. And you see we are 99.9%, making sure that the medication is checked against the MAR. Let's look at some of the analysis that we have reviewed over the past year or so. The results are reviewed quarterly by the Nursing Council and distributed throughout the nursing community. via newsletter, via many other venues. The quarterly report goes to the Medication Analysis Committee, and this is an inter and multidisciplinary committee. And this is where they go, the results are presented, and recommendations and action plans are formulated. We look at the efficiency of collecting data has increased over time. What used to take us a day to collect, now we can do it in half a day, because we have become so adept in terms of collecting the information. Nurses are increasingly comfortable with being observed in the more recent quarters. We have a double-check system to ensure that our data is accurate, and it ensures the integrity of our results. And our Director of Education, Katie Choi, was asked to be represented as part of the California Hospital Association Medication Safety Committee, based on the work we have done around medication observation and reducing medication errors. In terms of the action plan, when we first started, there was a lot of customization to be done, because every time the study was done, there were areas and challenges that we needed to work on. We have done many of those things. 6 West has a pilot in process to decrease distraction and interruption. They have the red medication vest. If any of you are on 6 West, you will observe during the medication administration process that the nurses wear a red vest. There's quiet time during the administration, and the phones are forwarded to the charge nurse during peak medication and administration times. Throughout the facilities, you will see the red line marking and signs around the medication carts for no interruptions, and they're beginning to forward the phone calls to the charge nurse on the other units as well. The pilot on 6 West, once they have worked out all the kinks, that's going to go house-wide. In order to improve administration technique, we had an issue in terms of how the medications were crushed and what medications should be crushed. There's now, I'm working with the pharmacist, message on the medication dispensing fixes that identifies crushable versus non-crushable medications. And the nurse receives a reminder before the medication administration. Future plans. Based on the Institute of Safe Medical Practice, they have made many recommendations to reduce distractions and interruptions. The first is focusing on preparation to ensure that all the needed supplies and documents are available prior to giving the meds. And we are beginning to look at that to see how we can make sure and to have everything situated in such a way that when the nurses are ready to give meds, everything is right there. We also are looking at creating a checklist of the important steps that needs to be done to be attached to a work area for reference when returning to complete a task. So in the event that there's any distraction, the nurse knows exactly where she left off and she can continue from there. So those are some of the things we are working on in terms of reducing medication errors. Any questions?
Any questions? Thank you very much, Stephanie. It looks like reducing the interruptions and distractions are our biggest challenge. And
It is.
our nurses are very busy people. And keeping those distractions and interruptions at a minimum during medication administration will help improve our medication safety. Medication safety has been a very important component of our emphasis on overall patient safety, and our whole team has worked very hard over the past several years to adopt best practices and really focus on medication safety at Washington Hospital. So thank you for presenting that information to us, Stephanie.
You're welcome.
Chris Henry, one-handed, finance report.
Okay, Joe. Okay, so tonight we'll be looking at the operational and financial results for Washington Hospital for November 2012. And we'll look into our census statistics. All our census statistics down below budget for the month. Average daily census came in at 157. We'd expected 183 in November. We had 952 admissions during the month. We'd expected 1,013. Patient days came in at 4,709. We had budgeted for 5,494. Our average length of stay for the month, and this is based on discharges, came in at 5.14. We had expected 5.42 in November. And excuse me for a minute as I get through my one-handedness. Moving into utilization. Case mix index in November continued on the trend we've seen the last couple of months, driven by the mix of services at 1.571. We had expected 1.432. We had 144 deliveries, just 5 below the budget of 149. However, the OR was busy. Surgical volume came in 42 above the budget at 404. That includes our joint replacement cases that were 12 above budget at 118. Our neurosurgical cases that were 8 above the budget at 20, and our cardiac surgical cases that were 5 above the budget at 14. PTCA procedures for the month came in very close to budget at 42, and cath lab overall had 81 more cases than we had expected in November. Outpatient visits for the month, however, were 583 below the budget at 8,168. And the emergency room saw 4,178 visits. We'd expected 4,111, so the ER volume a little bit above budget in November. Looking at our productivity, November saw 1,245 productive FTEs. We had 216.7 non-productive FTEs in the month, giving us total FTEs 2.5 above the budget at 1,461.9. Our FTEs per adjusted occupied bed, which is our productivity measure, came in at 7.04. We'd expected 6.14 in November. Moving into the financials. As always, we'll first look at our governmental representation of our governmental accounting standards presentation. That's the presentation used for our audited financials. Total patient revenue for the month came in $5.3 million above the budget at $172,539,000. Our contractuals for the month came in a little bit lower than we had anticipated at 75.22%, giving us net operating revenue almost $2.5 million above the budget at $43,046,000. Operating expenses for the month came in a little more than $1.3 million above budget at $42,227,000. We saw that in the areas of salaries and wages. We did have some severance packages that we had related to the downsizing that were paid in the month. Supplies were above budget related to the OR activity and also the cath lab activity. And of course, our provision for bad debt was above budget with our higher revenue numbers. So we end November with an operating bottom line of $769,000, about $1.1 million above the budget of loss of $354,000. Non-operating income for the month came in $684,000 above budget at a little more than $1.8 million, giving us a total bottom line for the month from a GASB perspective of $2.578 million. We'd expected $771,000 in the budget. Quickly looking at our Financial Accounting Standards Board presentation, and this is a representation of how the financial markets tend to look at us. We pull our unrealized gains on investments and our property tax revenue that's used for the servicing of our GO bonds out of non-operating income to give us non-operating income from a FASB perspective of $978,000 and a total bottom line a little bit more than $1.3 million above budget at $1,449,000, again from a FASB perspective. So are there any questions on November?
Very good. Thank you. Nancy, hospital?
Talk about December.
Good.
We saw 1,003 patient admissions that resulted in 5,143 days of care. The average daily census in December was 166. This was higher than November's average daily census, which was 157. The high and low census ranged from 188 down to 135. The budget for December had anticipated 1,110 admissions and 6,028 days of care and an average daily census of 194. So we're going to be approximately 885 patient days of care below the budget for the month. In terms of average length of stay for adults and children in December, it was lower than budget at 4.75. We had anticipated 5.43. The preliminary information indicates that the inpatient revenue for the month of December amounted to approximately $135,384,000, compared to the budget estimate of $141,362,000. Of this amount, 52.4% was Medicare and 6.7% was Medi-Cal, for a total of government program revenue at 59.1%. The Medi-Cal continues to be a problem for people trying to secure that benefit, and the waiting time stretching out as long as a year. So I'm a little bit curious to see what will happen with the state of California and whether or not they make the decision to go with the federal part of the program that extends Medicaid. Based on, okay, we've done that part. The birthing center saw 160 deliveries. We had budgeted 151. So, and that's interesting because just today there was an article in the Wall Street Journal about California's birth rate being below basic replacement. 2 children is considered basic replacement, and we're down at 1.9. The deliveries resulted in 358 baby days of care. Our newborns totaled 164, so we had some twins in there. By comparison, there were 153 deliveries at the hospital a year ago in the month of December. For the month of December, there were 348 surgical cases at the hospital versus a budget of 340. The operating room continues to be very busy. This includes cardiac surgical cases that were 11 above budget. There were 19 of them. Inpatient surgical activity was above budget by 20 cases, while outpatient surgeries were below budget by 12. 502 cases were seen at the outpatient surgery center versus a budget of 539. For the month of December, there were 398 cases seen in the cath lab, including 40 PTCAs. The total cath lab cases were higher than budget by 11.2%, or 40 cases, and PTCAs were lower than budget by 8, or a 16.7% variance. Inpatient cath lab procedures were 25 more than anticipated in the budget, while the outpatient procedures were 15 higher than we had expected. Outpatient visits for the month of December of 7,829 were 7.6% lower than our budget. Emergency room recorded a total of 4,512 patients, a daily average of 146, 212 patients above the budget. The Washington, Warm Springs, Newark, Nakamura, Ohlone, and Walmart clinics saw approximately 3,325 patients during December, 787 cases fewer than we had expected. So our total system emergency room and clinic visits for December come in at 7,837 compared to a budget of 8,412 visits. Full-time equivalents for the month of December totaled 1,431, including 2.3 agency personnel. So you can see that the trend remains with very tight control over agency. This was 53.5 FTEs lower than the budget. The FTEs per adjusted occupied bed were 6.66, which is above budget of 6.0, but that has to do with the inability to flex some departments that don't have that capability. Productive FTEs were above budget by 8.3 for the month. Non-productive were below budget by 61.8. In summary, we had 107 fewer admissions and 885 fewer patient days than we had anticipated in the budget. Our surgical cases are above budget by 8, and cath lab procedures were above budget by 40. Outpatient visits for December were 7.6% below the budget, while ER visits were 4.9% higher than anticipated. Clinic visits for the month were below budget by 19.1%. Total paid FTEs are below budget by 53.5, or a 3.6% variance, and below the last 12 months average by 60.6 FTEs. Inpatient charges for the month were lower than budget by approximately 4.2%, or $5,978,000. Outpatient charges were higher than the budget by approximately 1.8%, or $680,000. So total hospital charges for December will come in below budget by approximately 2.9%. On December 31st, there were 165 days cash on hand. The total days revenue and accounts receivable as of December 31st was at 57.93. The days revenue and accounts receivable excluding Medi-Cal were 53.28. During the month of December, $1,845,899 of charges were approved or are pending for charity assistance. So that number continues to hover in the 1.5 to 2 million range, with several months having gone over 2 million.
Great. Thank you, Nancy. It looks like our big challenge is to flex down when our census is low. Yeah, thank you.
I have a question.
Sure.
Have we started to experience any of the impact of the flu as
We're beginning to see the leading edge of it. The CDC reports that 41 of the 50 states have got epidemic levels of flu, and it is just now reaching Northern California. And we expect that to have a significant impact, particularly in the emergency room and in the clinics. And it's just now beginning.
ICU, and the ICU.
And the ICU, yes. People with chronic disease like pulmonary obstructive disease, if they get the flu, are put at severe risk. And those are the patients that tend to show up and be admitted to the critical care unit. Congestive heart failure patients are very frail, and flu can compromise them significantly. So my expectation is that we'll see that. All of the authorities are telling us that it's coming. So in the next few weeks, we'll see that develop, and we'll do our level best to help everybody.
Another challenge. Any other questions, comments? Thank you very much. We'll move on to a closed session.
Yes, please.
Okay, we're adjourned to a closed session. We're going to reconvene to open session and announce that no action was taken in the closed session, and there being no further business, this meeting is adjourned. Thank you.